minutes. It is now my great pleasure to introduce our first speaker, Professor Massimiliano Meineri from Germany, who is co-chair of the Department of Anaesthesia at Zentrum in Leipzig and Professor of Anesthesiology at the University of Toronto in Canada. And he's going to talk to us about the usefulness of echocardiography during open vascular and endovascular surgery. Just a quick reminder, please do be sure to type your questions into the Ask the Faculty box during the talk, and we will address all questions at the end of the four talks. And with no further ado, Massimiliano, the floor is yours.
So thank you very much for the kind introduction, and thank you very much for inviting me and giving me the opportunity to present on the use of echocardiography during open and endovascular surgery. My disclosure I've received, and I receive from time to time honorarium from Abbott to talk about clips. We are in Herzzentrum Leipzig, a reference center for Philips, but we don't. I don't get any money from Philips for that, and I'm also part of the board for the basic transesophageal echocardiography exam at the National Board of Echocardiography in the US. And the idea of this short talk was to talk a little bit about perioperative TTE. That is a topic that's very close to me and that I've been worked a lot in Canada and also here in Germany. We'll talk a little bit about the guidelines, the use of TE for hemodynamic assessment and to look at the aorta. And what I will not be talking about is the technical use of transesophageal echocardiography for guidance of endovascular stents, positioning, and detection of leaks. So this was from 5 years ago, now 6 years ago, that perioperative ultrasound, the future is now. There was Greg Janelle from Florida was writing with Martin London on anesthesia and analgesia, and the future is now, and the future is now 6 years later. Not really, unfortunately, there, but definitely, when we talk about point of care or focused transthoracic echocardiography, or we talk about the use of 5 views in 3 different windows without the use of Doppler in a patient who's a critical patient or a patient who's in the operating room or before or after the operation. And with these 5 views that are taken in clockwise fashion, we are allowed, according to the guidelines, to look at the following items and to answer yes/no questions on the size and function of the ventricles, on the presence of pericardial effusion, and the assessment of fluid status in the patient. There's an extended application that's supported by other guidelines is to exclude gross valvular pathology. And these are all extremely useful things to know, especially when we have an in vascular surgery. We get often patients in the middle of the night with like poor history. We're not really sure about what's happening with this patient. If we got all the information. And this was a short study that was done retrospectively in Scandinavia, where they looked at patients coming to the OR for non-cardiac surgery. Most of them were actually vascular patients. And on 112 patients, when they scanned the patient before putting them to sleep, they found in about one-fourth of the patient, unexpected findings. And these unexpected findings in 10% included aortic stenosis, hypovolemia, left ventricular hypertrophy, and presence of pleural effusion. All things that we probably want to know before we put someone to sleep for a big procedure, especially in an emergency situation. And actually using echo to detect or to assess fluid status is useful to prevent the patient from crashing. And this was another study for elective surgery done in the States, where what they did is they looked at the inferior vena cava variation with transthoracic echocardiography, and the patients with a collapsibility index or a change in the diameter of the inferior vena cava more than 43%, they had a much higher chance to become hypotensive with induction. So is it echo useful? Yeah, it is useful. It gives us information that probably prevents